This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Welcome to the Deep Dive, where we take complex clinical guidelines, cutting-edge research, and dense source materials and distill them into genuinely actionable, crystal-clear knowledge. Today, we are focusing entirely on the remarkable but often temperamental tube connecting your mouth to your stomach, the esophagus. Okay, let's begin with gastroesophageal reflux disease, GERD. For most patients, it's just heartburn, but the core problem is far more complex than just high acid output, right? The issue is often mechanical failure.
That's the crucial distinction, yeah. If we boil down the core pathophysiology, the most common causes are indeed mechanical. It usually involves a compromised or weak lower esophageal sphincter, the LES. But even more common is an increased frequency of those pesky, unplanned events we call transient LES relaxations, or TLESR.
TLESRs, right.
These allow gastric contents to escape upward. Certainly other factors contribute. A hiatal hernia physically disrupts that junction, or elevated intra-abdominal pressure can overwhelm the system.
So when a patient comes in with classic symptoms, heartburn, maybe some regurgitation, when does that investigative tool, the endoscopy, become mandatory?
Well, endoscopy is crucial when symptoms are unresponsive to medical therapy, or if there are red flags we worry about. New onset dysphagia, pain with swallowing, odynophagia, unexplained weight loss, or obvious signs of GI bleeding.
Okay.
However, you should realize that the majority of patients with GERD symptoms actually have a normal endoscopy.
Really? Most of them?
Yeah. We categorize that as non-erosive reflux disease, or NERD.
NERD. Got it. So if we do find erosions on that scope, the Los Angeles classification system provides that standardized language. Can you walk us through those grades and maybe more importantly, explain why grade C and D are such critical findings?
Sure. The LA classification, A, B, C, D, is about grading mucosal breaks. Grade A is minimal one or more breaks less than or equal to 5 millimeters that haven't bridged mucosal fold. Grade B is slightly larger breaks, more than 5 millimeter, but still confined to one fold. The real threshold comes at C and D. Grade C means breaks extending between at least 2 mucosal folds, covering less than 75% of the circumference.
And grade D is the most severe, involving more than 75% of the circumference. So finding a grade C or D is a truly critical shortcut. It saves the patient and the system the time and hassle of further testing.
Precisely.
Yeah.
Exactly. The presence of erosive esophagitis classified as C or D is specific enough for the diagnosis of GERD, precluding the need for pH testing to confirm acid exposure.
Wow.
It's definitive evidence of significant disease. Now, when we are retroflexing the scope to look back up at the junction, we also need to structurally assess the gastroesophageal flap valve.
Ah, right. Our source material highlights both the traditional Hill classification and the revised AFS hiatus grade. How do these help us understand the structural integrity there?
Well, the Hill classification is simple, running from type 1, which is a snug, protective fold of tissue, to type 4, a wide-open hiatal hernia. The newer American Foregut Society, AFS hiatus grade, moves us toward objectivity. It measures the hiatal axial length, or L, and the aperture diameter, D, essentially how long and how wide the junction is, and notes the functional status of the flap valve, F plus or F.
L, D, F.
Yeah. This precise, measurable description is absolutely essential if you are contemplating surgical intervention, as the structure must be conducive to a successful wrap.
That makes perfect sense. Structure guides the surgical option. But if the patient has NERD or the symptoms are unresponsive, we need functional testing. Tell us about the pH monitoring playbook.
Right. So pH monitoring, whether we use the wireless Bravo capsule or a 24-hour catheter with impedance, is how we objectively prove GERD exists in non-erosive cases. We are looking for a total acid exposure time, AET, of greater than 6% of the monitoring period.
6%, that's the magic number.
That's the key cutoff. If the AET is greater than 6%, you have objective GERD.
But the patient still needs to feel the symptoms, connect them to the reflux. How do we link those painful moments back to the reflux event itself?
That's where the statistical correlation metrics come in. The symptom index, SI, is considered abnormal if over half the patient's reported symptom episodes correlate with a pH less than 4 event.
Okay, over half.
But the symptom association probability, or SAP, is the most robust measure. SAP greater than 95% means the link between the symptom and the reflux event is statistically significant and highly unlikely to be just random chance.
SAP 95%, got it.
Importantly, impedance monitoring adds the ability to track non-acidic and weakly acidic events, which, as we'll get into later, is vital for managing refractory GERD.
Okay, let's discuss treatment. PPIs have been the gold standard for ages, but the conversation around their long-term safety has been fraught with anxiety fractures, kidney issues, even dementia fears.
Yeah, it really has. PPIs work by irreversibly inhibiting the proton pumps, H plus K plus AT paces. They're incredibly effective, but yes, the adverse event discussion has often overshadowed their benefits. It's important to share the source material's recent RCT finding. Pantoprazole was not associated with many of those commonly feared adverse events, fractures, dementia, or cancer, in the study population.
That's huge.
It is. The one exception noted was an increased risk of other enteric infections, like C. diff. But overall, this is a major finding that should genuinely reassure you and your patients about long-term use when it's truly indicated.
That significantly shifts the risk-benefit analysis back toward the benefit side. But what if the patient simply doesn't respond to standard dosing? Does that happen often?
It does. And then we need to consider pharmacogenetics. We might test for the CYP2C19 polymorphism.
Ah, the metabolizer status.
Exactly. If a patient is a rapid or ultra-rapid metabolizer of PPIs via that enzyme, the drug is cleared too fast, they may need a higher dose, or they might benefit from switching to rabeprazole, which is less dependent on that specific metabolic pathway.
Okay. But the biggest pharmacological news involves a completely different mechanism of action, the PCABs. Tell us about vonoprazan. This sounds like a massive shift.
Oh, here's where it gets really interesting. Vonoprazan is a potassium-competitive acid blocker, PCAB. Unlike PPIs, it is not a prodrug. It starts working right away.
Not a prodrug.
Okay. It reversibly blocks both active and inactive proton pumps by competitively blocking potassium binding. This means it doesn't need to be administered before a meal.
Big compliance advantage.
Huge. And it's significantly more potent, providing quicker and steadier acid inhibition throughout the day.
So it solves compliance issues, as it's not meal dependent, and it largely sidesteps the CYP2C19 variability. Given its reversible mechanism, are there entirely new side effect profiles or long-term concerns we should be tracking? Or does it simply solve the compliance and metabolism issues PPIs faced?
That's the key question moving forward, absolutely. Early data has been very positive, but the efficacy data is already groundbreaking. A randomized controlled trial showed vonoprazan to be superior to lansoprazole in healing and maintaining severe erosive esophagitis, LA grade CD, even in patients resistant to BD PPI.
Wow, superior for C and D.
Yeah. Now, it wasn't superior for NERD in that trial, but its proven benefit for severe erosions is a huge step forward, and it is now FDA approved for both erosive and non-erosive disease.
Okay. Moving to procedures then, what's the current thinking on anti-reflux surgery versus pills? Fundoplication still a major player.
Laparoscopic fundoplication, LHM, like a Nissen, is still a strong surgical option. We should acknowledge the Lotus trial, which showed PPIs actually had a slightly higher long-term remission rate at 5 years, 92% attendance, 85%, than LHM.
Interesting.
But surgery remains essential for many patients who cannot tolerate or comply with chronic medication. Then you have the laparoscopic magnetic sphincter augmentation, the Lane-Next system.
The Lane-Next system, those magnetic beads. Sounds futuristic.
It kind of is, yes. It essentially acts like a high-tech temporary zipper, keeping the LES shut until the pressure of a swallow unzips it. It augments LES pressure with a band of magnetic beads.
Huh. And on the endoscopic side, we have TIF and the controversial Stretta procedure. If TIF works well for certain patients, why is Stretta still considered controversial?
Good question. So, TIF transoral incisionless fundoplication creates a full-thickness, partial circumferential wrap endoscopically about 270 degrees. The RESPECT trial showed TIF was more effective than PPI therapy for patients whose main problem was regurgitation, not just heartburn.
Okay, good for regurgitation.
Right. It's best suited for patients with a small hiatal hernia and intact flap valves, like Hill type 1 or 2. The mechanism is a physical wrap.
Makes sense.
Stretta, however, uses non-ablative radiofrequency energy delivered to the LES to stiffen the tissue. While some studies show improvement, others show no difference compared to sham procedures. This variability in outcome is why the ACG currently does not recommend it, reflecting the lack of consistent high-level evidence of durability and efficacy across all meta-analyses.
Got it. Lack of consistent data on strata. Okay, let's transition to the frustrating situation where even optimized PPIs fail. What is the precise definition of refractory GERD, and what is the investigative mission when we encounter it? What are we trying to achieve?
Right, refractory GERD is defined rigorously as persistent, bothersome heartburn as more than twice a week for 3 months, despite optimal BD PPI therapy. So take it twice a day, correctly.
Okay.
The core mission of the subsequent workup is incredibly important. First, we must stop ineffective medications that may be causing unnecessary side effects. And second, we must find the true underlying etiology, which honestly is often not true acid reflux.
Fascinating. So what's the diagnostic path? The AGA guidelines mandate a few key steps, right?
They do. Start by optimizing PPI dosing. Make sure the patient takes the pill 30 to 60 minutes before meal, maximizing absorption. Can't stress that enough.
Right timing matters.
Absolutely. Next, an EGE is necessary, ideally performed off PPI for 2-4 weeks. We need to rule out structural lesions, Barrett's esophagus, and critically, we must biopsy to rule out eosinophilic esophagitis.
EOE again.
Which is surprisingly present in 1 to 8% of these refractory cases.
Wow, okay.
Now comes the truly crucial step, the pH testing algorithm. It changes depending on whether the patient has a history of proven GERD or not.
Okay, explain that difference. That sounds critical.
This is the nuance that defines management. If the patient has never had GERD proven objectively, say, they always had a normal scope, we perform the pH impedance test, OF PPI.
Off PPI if unproven.
Right. We want to know if they have acid reflux at all. If GERD was previously proven, say they had that LA grade C or D esophagitis we talked about, we perform the test on BAD PPI.
On PPI if proven.
Exactly. To evaluate how well the acid suppression is working and, importantly, to detect non-acid reflux using the impedance channels.
And based on that AET and symptom association, we categorize them into those 3 distinct groups. Walk us through those.
Okay. First group, pathologic AET, greater than 6% even while on BAD PPI. This is true GERD, and the PPIs are simply failing to suppress acid enough.
Truly refractory acid reflux.
Yes. Second group, physiologic AET, less than 4%, but with a positive symptom association, SAP 95%. This is reflux hypersensitivity. The patient has normal reflux levels, but they perceive these normal stimuli as painful. We sometimes call that allodynia or hyperalgesia, visceral hypersensitivity.
Perception issue, not an acid issue.
Okay.
Okay. And the third group, where reflux is essentially ruled out as the primary cause.
That's functional heartburn. This patient has normal AET and a negative symptom association. They feel heartburn, but it's not linked to reflux, acid, or non-acid. If they had no prior GERD diagnosis, they're purely functional. The key takeaway here is that categorization dictates therapy. You treat these 3 very differently.
Okay, so how does that categorization dictate treatment, especially for the patient who has truly refractory acid-related GERD, the first group?
Right. For those with truly refractory pathologic acid exposure despite BAD PPIs, surgical therapy appears superior. The special randomized trial is key here. It compared surgery, this is fundoplication, versus aggressive medical therapy, PPI plus neuromodulators like baclofen and desipramine, and found the surgical group had a significantly higher success rate, 67%, compared to only 28% in the medical group.
Wow, big difference. Surgery wins for true refractory GERD.
Seems so, based on that trial.
What about the functional group, where the problem isn't acid but perception? Group 3.
For purely functional heartburn, the primary step is counterintuitive but mandatory. Discontinue the PPI. It is ineffective and unnecessary. Management focuses on neuromodulators, often TCAs like imipramine or amitriptyline or SSRIs like fluoxetine, to modulate that visceral hypersensitivity. Crucially, if you have diagnosed functional heartburn, you must rigorously avoid anti-reflux surgery or endoscopic procedures like TIF. They will not fix the underlying hypersensitivity issue and may introduce new adverse events.
Makes sense. Don't operate on a perception problem. Now, we also use impedance to identify non-acid reflux. How do we manage that patient? Group 2-ish or maybe mixed?
Yeah, non-acid reflux involves reflux events with a pH greater than 4 that correlate with symptoms via impedance. Management starts with lifestyle changes, of course. Pharmacologically, baclofen is key.
Baclofen, how does that work?
It's a GABA agonist that specifically decreases those TLESRs, those transient relaxations that are allowing content, whether acid or not, to come up. It's particularly useful if regurgitation is the main symptom, not just heartburn.
Okay.
You must start low due to potential neurological side effects like drowsiness or dizziness. Additionally, alginate antacids, such as Gaviscon double action, are excellent mechanical tools. They create a protective raft barrier that physically floats on the stomach contents and prevents reflux.
Like a physical barrier. Interesting.
Exactly. Very helpful, especially if the LES barrier is weak.
Let's turn to extraesophageal manifestations, EGRD, such as chronic cough or hoarseness. This remains a highly controversial area for diagnosis because symptoms alone are so vague, aren't they?
Oh, absolutely. The San Diego consensus was crucial here. Laryngopharyngeal symptoms, LPS, were clearly defined as chronic, frequent cough, hoarseness, and throat clearing. Interestingly, symptoms like globus sensation or tongue burning did not reach consensus as reliably linked to reflux.
So just feeling a lump in your throat isn't enough?
Not based on that consensus, no. And LPRD, laryngopharyngeal reflux disease, is defined as having those LPS plus objective evidence linking it to reflux, usually from pH testing.
So we can't just rely on the ENT looking at the larynx and saying, oh, it looks red.
Exactly. That's a critical point. Laryngoscopy is essential to rule out other non-reflux causes, but physical laryngeal findings alone, like edema or erythema, are not diagnostic of LPRD. They're too non-specific.
Okay. So what's the implication for us?
For patients with isolated LPS, ambulatory reflux monitoring off PPI is suggested and preferred over just trying a PPI empirically. And it's definitely a prerequisite before considering any anti-reflux surgery for these symptoms. You need proof.
Proof before procedure. Got it. Does GRD contribute to uncontrolled asthma? That's another common belief.
Not always, and that's another key finding from our sources. A randomized trial found that asymptomatic GRD, even when confirmed by pH monitoring, was not a contributing factor to uncontrolled asthma in that study population. Therefore, eforprazole did not improve asthma control in those patients. So treating silent reflux didn't help the asthma.
Interesting. Finally, you mentioned the brain-throat connection. Tell me about the LCAT tool.
Right. We need to recognize this connection. The Laryngeal Cognitive Affective Tool, LSAT, can identify high anxiety or hypervigilance related to laryngeal symptoms. A score greater than or equal to 33 suggests this might be playing a role.
So it's about how much they worry about their throat.
Kind of, yes. Their perception and focus on it. These patients may benefit less from pills aimed at reflux and more from things like cognitive behavioral therapy aimed at laryngeal recalibration, or perhaps neuromodulators like gabapentin or TCAs.
Okay, let's shift to Barrett's esophagus, BE. Still the primary known risk factor for esophageal adenocarcinoma. How is BE precisely defined? And what about those short, confusing segments we often see near the GE junction?
Right. BE is histologically defined as specialized intestinal metaplasia goblet cells, essentially replacing the normal stratified squamous epithelium for a length of greater than or equal to 1 centimeter proximal to the GE junction.
1 centimeter minimum.
Yes. The key distinction is that segments less than 1 centimeter, sometimes called an irregular Z-line or short segment intestinal metaplasia, are generally considered specialized intestinal metaplasia of the GE junction itself and are not associated with the same increased risk of malignancy as true Barrett's.
Okay, that's an important cutoff. Now, the absolute risk seems to have been, well, reevaluated over the years. What is the current assessment of cancer risk in BE?
Yeah, the numbers have come down a bit. The absolute annual risk of adenocarcinoma in the overall BE population is lower than the historically cited 0.5%, ranging closer to 0.12% to 0.33% per year for non-dysplastic Barrett's.
Still low, relatively speaking.
Relatively low for non-dysplastic. However, the risk skyrockets significantly with dysplasia. Low-grade dysplasia, LGD, progresses at about 0.54% per year, and high-grade dysplasia, HGD, jumps dramatically to about 7% annually.
Huge jump with HGD.
Massive. Moreover, testing for abnormal TP53 expression in the Barrett's mucosa, even without visible dysplasia, can predict a higher risk of progression down the line.
P53 testing, okay. Given that lower general risk for non-dysplastic BE, who should we actually be screening? It can't be everyone with heartburn.
No, absolutely not.
Yeah.
Screening should be highly targeted, focusing primarily on high-risk men. The ACGHDHE guidelines recommend screening for men with chronic GERD symptoms for more than 5 years who also have at least 2 additional risk factors.
Okay, what are those factors?
A first-degree relative with BE or esophageal cancer, age over 50, Caucasian ethnicity, central obesity, or a history of smoking.
So GERD plus 2 of those in men. What about women?
Screening is generally not recommended for women unless they have a significantly high burden of multiple risk factors. The risk is just much lower in women overall.
Okay, targeted screening. Once BE is identified, standardized measurement is critical for follow-up.
Absolutely. We use the PROG classification, which mandates measuring the C, circumferential extent, and M, maximum extent of the metaplastic segment. So C2M5 means 2 centimeters circumferentially and a maximum tongue extending 5 centimeters up.
CNM, okay.
This standardized CM reporting allows physicians to accurately track disease extent progression or regression over time. It's the universal language.
We also have those emerging non-endoscopic screening methods challenging the traditional scope approach, like the cytosponge.
Yes, the cytosponge is the primary contender there. It's essentially a compressed sponge inside a swallowable capsule attached to a string. The patient swallows it, the capsule dissolves, the sponge expands, and then it's retrieved, collecting a wide sample of cells from the entire esophagus as it comes back up.
Wow.
These cells are then tested for the TFF3 protein, a marker associated with BE, and for genetic markers. It's a very promising, less invasive screening approach. We also sometimes use Watts 3D, which is like a specialized brush biopsy used during endoscopy to get wider sampling for pathology as an adjunct.
Okay, cytosponge and Watts 3D. Let's discuss management strategies based on the level of dysplasia found. What do we do?
All right. For no dysplasia confirmed, the rule is surveillance EGD every 3-5 years. Importantly, ablation is explicitly not recommended for non-dysplastic Barrett's.
No ablation if no dysplasia.
Got it. For low-grade dysplasia, LGD, or high-grade dysplasia, HGD, ideally confirmed by a second expert pathologist, endoscopic eradication therapy, EET, is the preferred approach. This usually means first resecting any visible nodular areas and then ablating the remaining flat Barrett's mucosa.
Eradication for any confirmed dysplasia. Now, I found the BioAssess trial particularly surprising. It suggests symptom-based endoscopy might be safe for low-risk patients instead of routine surveillance.
It is a challenge to current practice, yeah. The BioAssess randomized trial followed patients with mostly non-dysplastic BE and found that scheduled 2 yearly surveillance did not improve survival outcomes compared to simply performing endoscopy only as needed for new symptoms like dysphagia or bleeding.
So waiting for symptoms was just as good in that low-risk group.
In terms of survival in that trial, yes. It suggests that for the lowest risk BE patients, maybe less intense surveillance is warranted, although that's still debated and not universally adopted yet.
Food for thought. Now, on to eradication techniques. RFA, radiofrequency ablation, is the mainstay, right? How does that work?
RFA is key. It uses heat energy delivered via a balloon or focal catheter to essentially burn away the Barrett's tissue, allowing normal squamous tissue to regrow. The landmark RCT comparing RFA versus sham surveillance showed high eradication rates, significantly reducing disease progression from 16.3% down to 3.6% and reducing cancer rates from 9.3% down to 1.2% compared to the control group. It clearly works.
Impressive numbers.
Very. However, practitioners must be mindful that recurrence rates are still significant, around 20-33% following complete eradication, requiring indefinite surveillance even after successful treatment. It can come back.
Okay, lifelong surveillance even after RFA. When do we move from simple ablation to endoscopic resection techniques like EMR or ESD? And why is ESD now often preferred for larger lesions?
Right. Endoscopic resection is indicated for any visible nodular dysplasia or early cancer, T1A. For lesions larger than, say, 15 or 20 millimeter, the guidelines often recommend endoscopic submucosal dissection, ESD, over endoscopic mucosal resection, EMR.
ESD over EMR for bigger spots. Why?
Because ESD allows for en-bloc resection, removing the entire lesion in one single piece rather than piecemeal like EMR often does.
Oh, one piece.
Why is that crucial? Because removing it whole allows for highly accurate pathological staging, confirming the depth of invasion much more reliably. This helps us clearly differentiate between T1A, mucosal invasion only, and T1B, submucosal invasion tumors.
And that staging is critical for next steps.
Absolutely. Even for early T1B tumors, if the invasion is very superficial, SM1 less than 500 micrometers depth, it's considered low risk for lymph node spread and may still be managed endoscopically, potentially sparing the patient a major esophagectomy surgery. Precise staging matters immensely.
Okay, moving to another inflammatory disorder, eosinophilic esophagitis, or EOE. The diagnostic criteria here have seen radical changes recently, making it much simpler, haven't they?
Yes, huge simplification. The ACG 2025 guidelines simplify the definition dramatically.
Yeah.
EOE is now defined simply by symptoms like dysphagia or food impaction, plus the histology showing 15 or more eosinophils per high-power field, HPF, on biopsy.
15 EOs per HPF plus symptoms. That's it.
Pretty much. The major change is that PPI-responsive esophageal eosinophilia, PPI-REE, is now considered the same disease as EOE.
Ah, so the PPI trial is gone as a diagnostic step.
Exactly. PPIs are just recognized as a potential first-line treatment option, not an exclusionary diagnostic criterion anymore. It streamlines things considerably.
Okay. Clinically, what should alert us to the possibility of EOE beyond just a history of food impaction? Are there other clues?
Definitely. EOE is highly associated with other atopic conditions. Patients often have coexisting asthma, allergic rhinitis, eczema, or food allergies. It's part of that allergic picture for many people.
The atopic link.
Yes. Endoscopically, you look for the classic findings. Esophageal rings, which give the appearance of tracheal rings, sometimes called trachealization, longitudinal furrows or lines running down the esophagus, and white specks or patches, which are eosinophil microabscesses, often mistakenly treated as candida.
Okay, rings, furrows, white spots.
But the most telltale visual sign, I think, is the easily tearing crepe paper mucosa. The tissue is incredibly fragile and can split or tear just from the scope passing over it or from biopsies being taken.
Wow, fragile tissue. And to standardize disease tracking, we use the ERES scoring system.
Correct. ERES is an objective score encompassing edema, rings, exudates, furrows, and stricture. Each gets a score. This allows us to track disease activity over time, like saying a patient is E1R1 X0F1S0, giving a standardized measure of inflammation and structural change before and after treatment.
Useful for tracking response.
Very. And since EOE can be patchy, mandatory biopsies are non-negotiable 2-4 from the proximal esophagus and 2-4 from the distal esophagus, even if it looks normal.
Proximal and distal biopsies always.
Always. We need to contrast this with GER, which, if it causes eosinophilia at all, usually causes only mild inflammation, typically just distally. EOE is often panesophageal.
Got it. So, on to treatment. Since PPIs are now a first-line treatment, how are they working if they aren't just suppressing acid? What's the mechanism in EOE?
That's a great question. PPIs are now understood to have direct anti-inflammatory properties independent of their acid-suppressing effect, possibly related to blocking eotaxin 3 production or other inflammatory pathways.
Anti-inflammatory effect. Interesting.
Yes. They achieve clinical and histologic remission, getting below that 15 EOS-HPF threshold, in up to 50% of patients, but often require BD dosing, double the standard GURG dose, to reach that full anti-inflammatory potential.
BD dosing often needed. What about the topical steroids if PPIs don't work?
Topical steroids are a mainstay for non-responders or as another first-line option. This includes swallowed fluticasone, where the patient puffs the inhaler medicine without a spacer and swallows it, strictly avoiding eating or drinking for 30 minutes afterward.
Puff and swallow, no food or drink.
Right. Or budesonide, often given as oral viscous, budesonide, OVB, where you mix the Respule with something like Splenda to make a slurry. The new, highly successful formulation is the budesonide orodispersible tablet, BOT, which dissolves on the tongue and coats the esophagus as you swallow. It showed great success in trials for inducing and maintaining remission.
BOT, okay. Any downsides to steroids?
The main one is the risk of esophageal candidiasis, or thrush. It occurs in about 20% of patients using topical steroids, so you need to watch for that.
20% thrush risk. And the targeted biologic therapy, dupilumab.
Yes, dupilumab, DUPXNT, is a major advancement. It's a monoclonal antibody that inhibits interleukin-4, IL-4, and interleukin-13, IL-13, signaling, key drivers in type 2 inflammation, which underlies EOE and other allergies.
IL-4 and IL-13 blocker.
Correct. It's FDA approved for adults and children as young as 1 year old. This is particularly appealing for patients who have EOE plus coexisting atopic conditions like severe asthma or dermatitis, because it can treat both chronic issues simultaneously.
Dual benefit there. Finally, managing the mechanical result of chronic inflammation strictures. Dilation works well, but there's that perforation risk, around 0.3%. How aggressively do we push dilation in practice?
Dilation is highly effective for symptom relief associated with strictures, with about 90% of patients reporting improvement in dysphagia. But you are right to highlight the risk. The goal is to manage symptoms when the lumen diameter is too narrow, usually less than 13-15 millimeter. The key technique is start low, go slow, using graduated dilators or balloons, increasing the size gradually, maybe 1-2 millimeter at a time per session, up to a target diameter of 15-18 millimeter. You avoid overly aggressive jumps in dilator size to minimize that perforation risk.
To start low and go slow.
Exactly. And you must remember, crucially, that dilation does not treat the underlying eosinophilic inflammation. It only fixes the plumbing, widens the pipe. The inflammation requires ongoing medical therapy, PPI, steroids, or Dupixent, alongside the dilation to prevent recurrence of the stricture.
Okay, let's shift our focus to esophageal tumors. We categorize them primarily by type: adenocarcinoma, EAC, and squamous cell carcinoma, SCC. Let's start with adeno.
Right. Adenocarcinoma is the most common esophageal cancer in the United States and most Western countries. Its risk factors are linked directly to chronic acid exposure and inflammation. Barrett's esophagus is the big one, but also chronic GERD, obesity, and smoking.
The usual suspects for GERD complications.
Pretty much. The crucial point here, however, is the difficulty in catching it early. About 95% of new adenocarcinoma diagnoses occur in patients who lack a prior known BE diagnosis.
Wow, 95% without known Barrett's.
Yes, and maybe 40% of those patients deny previous GERD symptoms altogether. That makes population-based screening extremely difficult and highlights the risks that exist even outside the known Barrett's population.
That's sobering. And squamous cell carcinoma, SCC, has a different demographic and risk profile.
It does. SCC is more common globally, particularly in Asia and parts of Africa. And in the U.S., it's more common in Black individuals compared to Caucasians. Its risk factors are more diverse and include things like caustic injury, heavy smoking, heavy alcohol use, and chronic stasis conditions like long-standing achalasia.
Achalasia is a risk for SCC.
Yes, due to the chronic irritation from retained food and secretions. We also associate SCC with specific genetic syndromes like tylosis, a skin condition, and Plummer-Vinson syndrome.
Okay. Regarding staging and treatment, there's been a significant welcome shift toward endoscopic therapy for early-stage disease, right? Less surgery.
Absolutely. It's one of the big advances. The depth of invasion, defined by the TNM stage, is the decisive factor. For T1A tumors, that's invasion limited to the mucosa, lamina propria or muscularis mucosa. Endoscopic resection, like EMR or ESD, plus or minus ablation, is now the preferred therapy over esophagectomy.
Preferred over surgery for T1A.
Because clinical trials show similar long-term survival rates, but significantly lower morbidity, mortality, and better quality of life with endoscopic treatment compared to removing the esophagus.
Makes sense.
Even for early T1B tumors, those with superficial submucosal invasion, defined as SM1 invasion less than 500 micrometers into the submucosa, endoscopic resection is considered an acceptable alternative, especially in patients who are poor surgical candidates or who wish to avoid surgery.
Okay, good endoscopic options for early cancers. Speaking of SCC risk, let's talk about caustic injury, a high-yield topic with immediate and severe complications. Alkali versus acid.
Right. Immediate injury depends on the agent ingested. Alkaline ingestions, common in Western countries, like drain cleaner lye, cause deep, severe liquefactive necrosis. The tissue essentially dissolves, allowing deep penetration and widespread damage.
Liquefactive necrosis for alkali.
Yes. Acidic ingestions, like battery acid, sometimes more common in developing countries, cause coagulative necrosis. This creates a firmer eschar that tends to limit the depth of penetration, although it can still cause severe injury.
Coagulative for acid. Crucially, symptoms don't predict the damage.
Correct. The severity of symptoms like pain, vomiting or drooling, and even the presence or absence of oral burns does not reliably predict the extent of esophageal damage. You can have severe internal burns with minimal outward signs.
So an EGD is mandatory to assess the injury?
Yes. EGD is mandatory within the first 24 to 48 hours to visualize and grade the injury using Zargar's classification. This ranges from grade 0, normal, to grade 3B, extensive necrosis. The grade helps guide management, like deciding on NPO status, usually for grades 2B, 3A, 3B, potential steroid use, controversial, and prognosis.
Grade it early with EGD, but there's a tricky period after.
Yes, there is a strict contraindication window for endoscopy. EGD must be avoided between roughly 5 and 15 days post-ingestion. This is because the esophageal tissue becomes maximally softened and friable during this period, leading to a very high risk of perforation if you scope them then.
The soft phase avoids scoping. Okay, and the long-term cancer risk from this injury is quite delayed, isn't it?
It is. The main late complication is chronic stricture formation, which occurs in many severe burns and often requires repeated dilation sessions, sometimes starting after a predilation barium swallow to map the stricture. But the major malignancy risk is the long-term development of squamous cell carcinoma. typically 15 to 20 years or even longer after the initial injury. The lifetime risk is significantly elevated.
So they need long-term surveillance.
Yes. Because of that high SEC risk, screening EGD is recommended starting 10-15 years after the initial insult, repeated perhaps every 1-3 years thereafter.
All right, this is where we move into functional diagnostics.
Yeah.
High-resolution manometry, HRM, and the Chicago classification version 4.0 have brought incredible precision to these diagnoses. What are the key metrics that define normal esophageal function when we do manometry?
HRM gives us this beautiful pressure topography map. The key measurements under Chicago 4.0 are, first, the integrated relaxation pressure, or IRP. This measures how well the lower esophageal sphincter relaxes during a swallow. An elevated IRP means impaired relaxation. The abnormal cutoff varies slightly based on the specific catheter system used, but it's typically around 15 millimillar Hg for one system, maybe 22 for another.
Okay, IRP for LES relaxation, what else?
Second is the distal contractile integral, or DCI. This measures the vigor or strength of the esophageal body contraction after the swallow. A normal swallow should have a DCI between 450 and 8,000 millimillar Hg a centimeter.
450 to 8,000, that's the normal power range.
Exactly. Third, distal latency, or DL. This measures the speed of the contraction, specifically the time from the start of the swallow to the contractile deceleration point. Anything less than 4.5 seconds is considered too fast or premature, indicating a spastic component.
DL 4.5 seconds means spastic. Okay, and the new kid on the block, the endoflip. Why is that useful? If we already have manometry, what does it add?
Good question. The functional luminal imaging probe, endoflip, is complementary. It uses impedance planimetry during volume-controlled distension, usually with a balloon catheter placed across the GE junction during endoscopy. It measures the distensibility or stretchiness of the GE junction, essentially how easily it opens under pressure.
So it measures opening, while manometry measures relaxation pressure.
Kind of. Manometry measures LES relaxation pressure. Endoslip measures distensibility or the cross-sectional area for a given pressure. They often correlate, but not always. When manometry is borderline, or if a patient has persistent symptoms after a myotomy for achalasia, endoflip gives us critical insight. Low distensibility index DI values correlate strongly with untreated achalasia and can predict poor symptom response after treatment if that stretchiness remains low post-myotomy.
Helpful when manometry is unclear or post-treatment. Okay, let's focus on achalasia. We know the pathophysiology is the selective loss of inhibitory neurons in the myenteric plexus, but how does Chicago 4.0 divide the subtypes, and why does that subtyping matter so much for treatment?
Right, achalasia subtypes are crucial because they dictate prognosis and help guide the preferred treatment. All subtypes share that impaired LES relaxation, high IRP.
High IRP is universal in achalasia.
Yes, then it's about the body. Type 1 is classic achalasia 100% failed peristalsis. No useful contractions, and no significant esophageal pressurization. Just a quiet, non-contracting tube above a tight sphincter.
Type 1 classic.
Type 2 is distinct because 20% or more of swallows show panesophageal pressurization. The whole esophageal body pressurizes simultaneously, often 30 millimillar Hg. It's compressed, not just non-contractile. This subtype actually has the best overall prognosis and responds very well to pretty much any treatment, especially pneumatic dilation or Heller myotomy.
Type 2, panesophageal pressure, best prognosis. And Type 3?
Type 3 is the spastic type. It's defined by preserved fragments of peristalsis, or more commonly, premature or spastic contractions, DL 4.5 seconds, in at least 20% of swallows, along with the high IRP.
Type 3 is the spastic one. This is the one that causes the most distress, often presenting with chest pain along with dysphagia, and requires the most aggressive approach, right?
Exactly. The spastic nature makes it the most difficult to treat. Standard treatments like dilation or Heller myotomy might not be sufficient. POEM, or peroral endoscopic myotomy, is often considered the preferred treatment for type 3 achalasia.
Why POEM for type 3?
Because the endoscopic tunneling technique allows the endoscopist to perform a much longer myotomy, cutting the muscle higher up the esophagus to target the entire spastic segment, which is often necessary to overcome that premature contractility. You can tailor the length precisely.
Longer, tailored myotomy with POEM. Okay. When we compare the three main treatment options across all types, POEM, pneumatic dilation, PD, and laparoscopic Heller myotomy, LHM, with a partial fundoplication, what are the key trade-offs we need to be aware of based on trials?
Right, the trials showed generally similar efficacy overall, but different complication profiles and perhaps subtle differences by subtype. The European trial comparing POEM versus PD found POEM had higher success rates at 2 years, 92%, 54% using a strict definition, but PD had a much lower rate of post-procedure reflux esophagitis.
Better success, but more reflux than dilation.
Correct. The trial comparing POEM versus LHM showed similar long-term success rates at 2 years, around 82% for both. But again, POEM had a significantly higher incidence of post-procedure esophagitis and objective GRD on pH testing, often requiring long-term PPI therapy afterward. LHM includes an anti-reflex wrap, which POEM doesn't.
Similar success for POEM versus Heller, but POEM again has more reflux.
That seems to be the pattern. Ultimately, all three, POEM, PD, LHM, remain valid options. The decision needs to be customized based on the achalasia subtype. Type 3 favors POEM, Type 2 does well with anything. Patient factors, age, surgical risk, physician expertise, and the patient's willingness to manage potential post-procedure GOR, especially after POEM. Got it. Personalized decision. Is there a specific complication we need to watch out for after a myotomy, maybe years later, if symptoms recur?
Yes. One specific entity is the blown-out myotomy, or BOOM. This is essentially a wide-mouth pseudodiverticulum, or outpouching, that can develop at the site of the previous myotomy, usually in the distal esophagus, sometimes years after Heller or POEM.
A pouch forms where the muscle was cut.
Exactly. It represents a dilated, poorly functioning distal segment that can trap food and cause recurrent symptoms of dysphagia, regurgitation, or chest pain, indicating treatment failure or a late complication. It may require further intervention.
BOEM may, okay. Let's briefly cover the other key motility disorders defined by Chicago 4.0. What about the spastic or high vigor ones?
Sure. Besides type 3 achalasia, we have other disorders of hypercontractility. Distal esophageal spasm, DES, is defined by premature contractions, DL 4.5 seconds in at least 20% of swallows, but with a normal LES relaxation, normal IRP, often presents with chest pain and dysphagia.
DES, fast contractions, normal LAS relaxation. Right. Then there's hypercontractile esophagus, often called jackhammer esophagus. This involves excessively vigorous contractions, defined by a DCI greater than 8,000 milli-AGS centimeter in at least 20% of swallows. These can be painful.
Jackhammer, super strong contractions. How are these treated?
Treatment for both DES and jackhammer often involves symptom control first. PPIs are usually tried, as reflux can trigger spasm, then medications to relax the smooth muscle or modulate nerves, like calcium channel blockers, diltiazem, nifedipine, nitrates, low-dose TCAs, imipramine, amitriptyline, or even sildenafil. Sometimes botulinum toxin injection into the esophagus, or even POEM for refractory cases.
Okay. And finally, EGOO, esophagogastric junction outflow obstruction. Sounds like achalasia, but isn't.
Correct. EGOO is characterized by an elevated IRP, impaired LES relaxation, just like achalasia, but with intact or normal peristalsis in the esophageal body. It doesn't meet the criteria for any subtype of achalasia.
High IRP, normal body function. What causes it?
It's often a diagnosis of exclusion. Some cases are mechanical, caused by something physically obstructing the junction like a tumor, stricture, or a tight surgical fundoplication wrap. Opioid use can also cause it. Many cases, however, appear functional and may resolve spontaneously or represent very early achalasia.
So how do you approach it?
Because it can be functional or transient, you must use further testing, like a timed barium swallow or endoflip, to confirm there's truly clinically relevant obstruction, holdup of barium, low distensibility, before jumping to invasive LES weakening therapies like dilation, Botox, or POEM. You don't want to treat a manometric finding if it's not causing a real problem.
Okay, let's quickly review some specialized topics to round things out, starting with infectious esophagitis, particularly in the immunocompromised setting like HIV. This is a high-yield area because the location of the biopsy depends on the suspected culprit, right?
That's the key memory point, absolutely. The three major players you need to differentiate are Candida, CMV, and HSV. Candida is the most common. It typically presents with oral thrush and dysphagia, and on endoscopy you see characteristic white plaques or patches. Usually we treat empirically with fluconazole without needing biopsy confirmation if the presentation is classic.
Candida, white plaques, treat empirically. What about CMV?
CMV, cytomegalovirus, tends to cause more severe symptoms, especially odonophagia, painful swallowing. And endoscopically, it classically causes large, somewhat deep, linear, or ovoid ulcers, often in the mid to distal esophagus. For CMV, the virus is replicating in the endothelial cells and fibroblasts at the base of the ulcer, so you must biopsy from the center of the ulcer base.
Biopsy the center for CMV. What are you looking for?
Histologically, you're looking for the pathognomonic large cells with owl's eye inclusions, those large basophilic intranuclear inclusions. Treatment is antiviral, typically ganciclovir or valganciclovir.
That's owl's eyes in the center. And for HSV, herpes.
For HSV, herpes simplex virus, It classically causes multiple smaller, well-demarcated, punched-out appearing ulcers, sometimes with a volcanic shape. They often occur more proximally. Since HSV infects the epithelial cells at the edge of the active lesion, you must biopsy from the margin or edge of the ulcer.
Biopsy the edge for HSV. And the histology.
Histology shows the classic 3Ms, multinucleated giant cells, nuclear molding, nuclei conforming to each other, and margination of chromatin along the nuclear membrane.
You might also see Cowdrey type A intranuclear inclusions. Treatment is acyclovir or valacyclovir.
3Ms from the edge. Perfect. Are there other ulcers in HIV?
Yes, sometimes patients develop idiopathic HIV ulcers, also called aphthous ulcers. These are typically large, deep ulcers, often single, that are negative for CMV, HSV, fungi, and malignancy on biopsy. They seem related to immune dysregulation and often respond well to systemic corticosteroids or sometimes thalidomide.
Okay, moving to structural conditions. Let's start with pill-induced esophagitis, a really common pitfall in practice if you don't think about it. Absolutely. Pill-induced esophagitis causes acute onset chest pain, odynophagia, and dysphagia due to direct caustic injury or prolonged contact of a pill with the esophageal mucosa. Endoscopically, you usually see one or more discrete ulcers, sometimes with surrounding inflammation, often in the mid-esophagus where there's natural compression by the aortic arch or left atrium.
Mid-esophageal ulcers, what are the classic culprits?
The big ones to remember are certain antibiotics, especially tetracyclines like doxycycline and also clindamycin. Bisphosphonates used for osteoporosis like alendronate are notorious. NSAIDs, potassium chloride tablets, and iron supplements are also common offenders.
Doxy, bisphosphonates, NSAIDs, potassium.
Yeah. The crucial learning point for prevention is simple patient counseling. The patient must take these pills with a full glass of water, at least 4-6 ounces, maybe even 8 ounces, around 200 ml, and very importantly, remain upright, sitting or standing, for at least 30 minutes, maybe even an hour for bisphosphonates, after swallowing to ensure the pill clears the esophagus quickly. Don't take them right before lying down.
Full glass of water, stay upright. Simple but vital. Okay, what about some of the rare, more ominous conditions, like black esophagus?
Acute esophageal necrosis, or black esophagus, is a rare but dramatic and often high mortality condition. It's typically seen in critically ill patients who are hypotensive, septic, diabetic, or have severe underlying comorbidities. Endoscopically, you see a striking circumferential black discoloration of the distal esophagus, usually stopping sharply at the GE junction.
Black distal esophagus in sick patients, what causes it?
It's thought to be ischemic injury, possibly combined with massive reflux of injurious gastric contents in a low-flow state. Treatment is supportive care for the underlying critical illness, nilperos, NPO, and high-dose intravenous PPIs. Mortality is high due to the underlying conditions.
Okay, what about the inlet patch? Incidental finding, usually.
Yes, the heterotopic gastric mucosal inlet patch is a congenital finding a patch of pinkish-orange gastric-type mucosa located in the upper esophagus, just below the upper esophageal sphincter. It's found in maybe 1-10% of endoscopies if you look carefully. It's usually asymptomatic and considered benign.
So usually do nothing.
Generally, yes. If found incidentally, requires no treatment or surveillance. Rarely, it can cause symptoms like globus, dysphagia, or acid-related symptoms due to acid production from the patch itself. In highly selected symptomatic cases, ablation, like with RFA or argon plasma coagulation, is sometimes attempted, but it's controversial and not standard practice.
Okay. Finally, let's wrap up with the structural oddities, starting with the cricopharyngeal bar and then diverticula.
Right. The cricopharyngeal bar is primarily a radiologic finding seen on barium swallow. It looks like a smooth posterior indentation at the level of the pharyngoesophageal junction, around C5-C6. It's thought to be due to hypertrophy or incomplete relaxation, achalasia, of the cricopharyngeus muscle, which forms the upper esophageal sphincter.
So a tight UES causing an indent on barium.
Essentially, yes. Increased UES pressure and decreased compliance during swallowing. Most are asymptomatic. However, if it causes significant oropharyngeal dysphagia difficulty initiating a swallow, food sticking high up the treatment is mechanical disruption. This usually involves aggressive, wire-guided bougie dilation through the UES, typically up to a large diameter like 48 to 60 French, to stretch or tear the muscle fibers. Sometimes cricopharyngeal myotomy, surgical or endoscopic, is needed for refractory cases.
Aggressive dilation for the bar if symptomatic, and the two major esophageal diverticula, Zenker's and epiphrenic.
Yes. The most common is Zenker diverticulum. This is a false diverticulum, mucosa and submucosa, herniating through muscle that occurs in the posterior hypopharynx, specifically through a weak spot called Killian's triangle, just above the cricopharyngeus muscle. It's a pulsion diverticulum thought to arise from UES dysfunction.
Zenker's posterior above the UES. Symptoms.
Classic symptoms include oropharyngeal dysphagia, regurgitation of undigested food, often hours after eating, chronic cough from aspiration, and halitosis, bad breath, due to decomposing trapped food. Modern treatment strongly favors flexible endoscopic septotomy, cutting the septum between the diverticulum and the esophagus using various endoscopic tools, sometimes called ZPOM now, much less invasive than traditional open surgery.
ZPOM for Zenker's. And the epiphrenic diverticulum.
An epiphrenic diverticulum is also a pulsion diverticulum, but it's located in the distal 10 centimeters of the esophagus, usually just above the lower esophageal sphincter. These are almost always associated with an underlying esophageal motility disorder, most commonly achalasia or sometimes distal esophageal spasm.
Epiphrenic distal, related to motility disorder.
Exactly. The high intraesophageal pressure generated by the dysmotility is thought to cause the pouch to form. Therefore, treatment must address the underlying motility disorder, Heller myotomy for achalasia, usually along with resection or management of the diverticulum itself, often done surgically, laparoscopically, or thoracoscopically. Just fixing the pouch without fixing the motility issue leads to poor outcomes.
Wow. We've truly covered the entire chapter on the esophagus, haven't we? From the sophistication of new acid blockers like vonoprozin, through the really customized treatments for achalasia subtypes based on manometry, and that crucial distinction between functional versus true refractory G or D. Lots of key takeaways.
Absolutely. I think the overriding theme again and again is the absolute necessity of objective testing, pH monitoring, manometry, endoflip biopsies to move beyond subjective symptoms and get to the right diagnosis, especially when initial treatments fail. Knowledge is power here, whether it's matching POM to type 3 achalasia or recognizing that PPIs are actually acting as anti-inflammatory drugs in the context of EOE.
It's clear that the diagnostic landscape has improved immensely, allowing for much more precision. Yet a major challenge seems to remain with early cancer detection, particularly adenocarcinoma.
Which brings us neatly to our final provocative thought for you, the listener, to consider. We noted that source finding that 95% of esophageal adenocarcinoma patients lack a prior Barrett's diagnosis, yet we also have potentially effective, less invasive screening tools like cytosponge emerging. And we know the cure rate for very early stage T1A cancer treated endoscopically is excellent. So the question is, given these facts, should screening guidelines eventually be broadened beyond the current, highly specific high-risk criteria, focused mainly on men with multiple risk factors? Could a less invasive tool allow us to capture more of these cancers at that earliest, most curable stage in a wider population? It's compelling but complex cost-benefit calculation that health systems will inevitably have to grapple with as technology continues to advance.
A truly challenging question for the future of foregut medicine indeed. Thank you for joining us for this deep dive into the intricate world of the esophageal tract. We hope this has provided you with the actionable knowledge you need for your practice or your learning.